Female reproductive pathology, a good topic, not too hard, not too easy, but some of the things could be a bit confusing. This I made mostly from the book. What is not from the book has its resource linked below. I think it's very important for you to use official resources, namely your professors and teachers. Please do not disregard the lectures. They are very, very useful. Tumors of the vulva and the vagina. Benign tumors of the vulva. We can start by mentioning condyloma acuminata, which is the HPV wart, condyloma latum, which is the secondary syphilis wart-like lesion, and fibroepithelial polyps and squamous papillomas, which we still are unsure about their pathogenesis. Other benign tumors of the vulva would include hydranodena papilliferum, a rare benign cystic tumor of apocrine gland that can be anywhere in the anogenital region, but labia minora and labia majora are common places for it to arise. It is seen in middle-aged adults. Epidermal inclusion cyst is when the pilosebaceous unit is obstructed. Secondarily to trauma is what happens often, but it could be spontaneous. And then the keratinizing squamous epithelium is entrapped and the area is becoming cystic. Vestibular gland cyst is a cyst of the minor vestibular gland. Please always remember that there are many pathologies that you should remember from general pathology that can arise pretty much anywhere. Fibroma and lipoma are benign lesions that can arise in many areas. The vulva is one of them, and fibroma of the vulva is the most common benign solid tumor of the vulva. Squamous neoplastic lesions of vulva, malignancies and premalignancies. So in general, any carcinoma of vulva is not very common, and in all of the female reproductive tract cancers, only 3% arise on the vulva. The most common vulvar cancer is the squamous cell carcinoma, SCC, and we generally look at it as one of two major classifications. The first one is the high risk associated one, and the second one is the HPV unrelated or unassociated one. So the first one presents as either basiloid or warty subtypes. It is amount to 30% of vulvar SCCs, and it is seen in old adults but younger ages compared to the second subtype, which include the keratinizing subtype presentation. It is more common and it arises in people in their 80s. Next, each of these have a precancerous lesion that predisposes it. For the basiloid and warty one, the HPV associated ones, there is the UVIN, usual VIN. VIN stands for vulvar intraepithelial neoplasia. The differentiated DVIN is the precursor to the HPV unrelated one, and that one is often associated with lichen sclerosus. Another name for DVIN is VIN simplex. VIN is divided into VIN 1, 2, and 3 based on the involvement or the thickness of involvement of the epithelium. If only 33% or less of the thickness of the epithelium are dysplastic cells, the prognosis is good, and in fact there is a high chance that the body can mitigate it and there will be regression of this dysplasia. If it's more than 33 but less than 66% thickness of the epithelium, then the risk is higher for bad prognosis. The chance of regression is lower, but it is still present. And then in VIN 3, it is between 66% and 99% of thickness. And the chance of regression is only a few percentages. The prognosis is much worse. Of course, if it is 100% thickness of the epithelium covering, we call it a carcinoma in situ. And if it goes above the 100%, meaning it invades, then it's no longer a carcinoma in situ, but invasive carcinoma. The modern, newer terminology, instead of VIN 1, 2, and 3, is LCIL and HCIL. standing for low and high squamous intraepithelial lesions. Low SIL replaced VIN 1. High SIL replaced VIN 2 and 3. Remember that because LSIL is associated with HPV, then histologically it shows choliocytosis, like the warts with low-risk HPV. HSIL, because it is unrelated to HPV, shows no choliocytosis. So I think this is a great picture just to understand the bigger scale of things. How come we had, let's say, VIN and VAIN and CIN1, and we connect them with choliocytosis, and we connect them with other pathological terminology like mild dysplasia versus the severe dysplasia of CIN, VIN vein 2 and 3, and how those were unified into LSIL and HSIL in the newer classification. Glandular neoplastic lesions of the vulva. It's important to mention that in the vulva as well, there are some modified apocrine sweat glands that are very similar to the ones seen in the breasts, and therefore there are a few pathologies that histologically speaking are pretty much the same or very similar to the ones in the breast. Papillary hidradenomas, also called hidradenoma papilliferum, is a rare benign tumor of apocrine gland in the anogenital region of 30 to 50-year-old females. The lesion is sharply circumscribed and is common on labia majora and minora, and it can be confused with carcinoma because it can ulcerate. What is important to mention is that because the vulva has modified apocrine gland tissue similar to the one in the breast, some lesions of this gland tissue looks very similar to lesions of these apocrine glands in the breast. This is one of them. Extramammary Paget disease, again, notice the similarity to breast lesions. So what is Paget disease? It is an intraepithelial proliferation of malignant cells, but quite different than what we're used to. Microscopically, Paget cells are larger than the surrounding keratinocytes. They have a paler cytoplasm and are either seen alone or in small clusters within the epidermis. This diffuse layout throughout the epidermis itself is what we call pagetoid spread. This is pretty much the same as Paget disease of the breast looks like. Macroscopically, it presents as a pruritic red crusted map-like area, often on labia majora. The discussion about primary and secondary disease is very interesting. Paget disease of the nipple is almost always secondary, but vulvar Paget's disease is not. This is because the pagetoid spread from the underlying carcinoma seen in the breast is secondary. First you have ductal breast carcinoma, and then you have something like seeding of the overlying epithelium with this pagetoid spread. But in the vulva, it can be primary. So that means there is no underlying adenocarcinoma, and yet the epidermis has some pagetoid spread of neoplastic cells. So the believed pathogenesis is via these Toker cells, which are some sebaceous cells derived cell, and it is undergoing some primary neoplastic changes. But keep in mind that in the nipple, it's always secondary to adenocarcinoma. In the vulva, it's not. Paget cells spread laterally within the epidermis beyond the confines of grossly visible lesion. Thus, excision is often not wide enough and the disease can recur. Intraepidermal Paget disease may persist for many years or decades without invasion or metastasis. In the rare instances where invasion develops, the prognosis is poor. Premalignant and malignant neoplasms of the vagina. A word about the benign tumors. They mostly occur in reproductive age women. A few good ones to mention is stromal tumors, leiomyomas, also called fibroid, and hemangiomas. The premalignant lesion here is vaginal intraepithelial neoplasia. Like we had VIN, now we have VAIN. The primary malignancy that is most important to discuss is squamous cell carcinoma. And the secondary malignancy that is most important to discuss is spread of carcinoma from cervix into the vagina, which is in fact more common than the local primary malignancies. In infants, sometimes we can see embryonal rhabdomyosarcoma, also called sarcoma boitrioides, vaginal intraepithelial neoplasia, and SCC. Virtually all primary carcinomas of the vagina are squamous cell carcinomas, ones that are associated with high risk HPV, and they're mostly present in women after the age of 60. Vaginal squamous cell carcinoma is overall very uncommon and represents only 1% of female genitalia malignancies. Its risk factors are previous cervical squamous cell carcinoma, and perhaps the person has some genetic susceptibility for neoplasms. Vaginal SCC arises from vaginal intraepithelial neoplasia, which is its pre-malignant lesions, aka squamous intraepithelial lesion. In the upper one-third of the vagina, the SCC spread to the regional iliac lymph nodes, and in the lower two-thirds of the vagina, the carcinoma spreads to the inguinal lymph nodes. The clinical picture is of leukoplakia, bleeding, and ulceration. The tumor is aggressive and doesn't have good prognosis. Embryonal rhabdomyosarcoma, also called sarcoma boitrioides, it's a vaginal tumor of malignant embryonal rhabdomyoblasts. It is most often seen in infants and children under the age of 5. The clinical picture is polypoid, bulky, grape-like clusters protruding out of the vagina. The microscopy is of rhabdomyoblasts, spindle-shaped blue cells. It is confirmed with immunohistochemistry to prove the presence of the SMIN. The tumor tends to invade locally, causing death by penetration into the peritoneal cavity or urinary tract obstruction. Of course, the death or the heavy damage is because of complication from these. For example, some severe reflux nephropathy from the urinary tract obstruction. The treatment is surgery and chemotherapy. Thank you for listening, and apologies for the change in tonality in between slides. I got a sore throat in the middle of recording it, and I had to redo some of the slides. Some of them I kept.